Tell me more about phaeochromocytoma. So what is in a name? The name phaeochromocytoma describes its appearance, as pheo means dark, chromo means color, cyt means cell, and oma means tumor. A phaeochromocytoma is a rare tumor that forms in the inner part of an adrenal gland, where its cells darken as the tumor forms. There are normally two adrenal glands, so called because they sit on top of the kidneys, and they have an outer layer called the cortex and an inner layer called the medulla. In the medulla there are chromaffin cells where hormones called catecholamines are produced. These hormones include adrenaline and noradrenaline. These are the hormones responsible for fight or flight responses, and normally adrenals secrete these hormones in a controlled way at times of stress or when something scary happens. These hormones bind to receptors called alpha or beta receptors, which are found in various places in the body, such as the heart. Receptors are like docking stations for these hormones. Think of the hormone as a plug and receptors as the socket the plug goes into. Catecholamines binding to the receptors can cause an increase in cardiac output, blood pressure to increase, dilated pupils, more blood flow to muscles, and increase in blood sugar. All to facilitate an adequate response by the body to the stressor. Phaeochromocytomas can develop in the inner part of the adrenals, the medulla. As such, they often make more of the catecholamine hormones than is normal, and so causing symptoms that can affect the whole body. Sometimes when this type of tumor develops elsewhere in the body, they can be described as extraadrenal phaeochromocytomas or paragangliomas. Phaeochromocytomas can arise sporadically, or they can be part of an inherited syndrome, such as multiple endocrine neoplasias type 2A and type 2B, also known as MEN2, which occur if there is a mutation in the RET gene, which becomes an oncogene, meaning that it leads to uncontrolled cell growth and multiplication and the development of tumors. Another inherited condition associated with phaeochromocytoma is von Hippel-Lindau disease, which occurs when there is a mutation in the VHL gene. This gene normally is a tumor suppressor gene, so stopping cell growth. However, when mutated, there is a loss of this control function on cell division, so tumors can develop. Another disease is neurofibromatosis type 1, which occurs when there is a mutation in the gene NF1, which also normally encodes a tumor suppressor protein. So when mutated, it works in the same principle by resulting in uncontrolled cell proliferation. Once a phaeochromocytoma develops, it causes unregulated overproduction of catecholamines and can result in difficult symptoms, of which the most common ones are high blood pressure, sweating, headaches, palpitations, and anxiety or panic attacks. Phaeochromocytoma can be diagnosed incidentally when a patient has imaging such as a CORT scan, or more intentionally by carrying out testing of blood or urine. Specific tests can include looking at catecholamine levels or the levels of their breakdown products called metanephrine. If these tests are suggestive of a phaeochromocytoma, then scans can help to find its location in the body. These scans can be a CT, MRI, or more specialist scans such as an IMIBG scan that uses a chemical and a mildly radioactive agent to stick to the tumor cells. This then gets picked up in the scan. Other scans include FDG PET, GAR-DOTATATE PET scans. Treatment for hormone-producing phaeochromocytomas is usually surgery. However, medication is usually needed to make sure that the blood pressure stays stable prior to and during surgery, to reduce the operative risks. These medications are called alpha and beta blockers, and they act on the previously mentioned receptors or docking stations, and so block the effect of the catecholamines that are present in excess. If post-surgical follow-up shows a deficiency of the hormones produced by the adrenal glands, then lifelong replacement will be needed. For patients who cannot have surgery, or in addition to surgery, other treatments may include targeted radionuclide therapy, using MIBG as an example, or chemotherapy. Post-treatment, a discussion with the medical team is needed to talk through ongoing surveillance as well as any additional genetic counseling required for the patient and their family. Patients require the support of a full multidisciplinary team to provide the wide range of expertise and skill to manage this condition and help individuals on this journey, which also includes their emotional well-being as well as the medical and surgical management of phaeochromocytomas.